Good morning to all of you. Now, in the last few lectures, we had finished the whole spectrum of phonotruncal anomalies, which forms a major component of the congenital heart diseases. We now come to another type of congenital heart disease, which is fairly frequent and not at all uncommon. It may be seen in isolation or in combination with other congenital heart diseases. So today I will be talking on AV canal defects. Now, this AV canal defect actually stands for atrioventricular canal defects, and it has been known by various names. The older ones were like canalis atrioventricular communis, persistent atrioventricular ostium. Primarily, it is an endocardial cushion defect. So many people call it just endocardial cushion defects. The other popular name is atrioventricular septal defects. So this is the term that is used most frequently nowadays. And as I told you, it is not at all uncommon and constitutes around 4 to 5% of congenital heart diseases. It occurs in about 0.19 in around 1,000 live births. Its association with Down syndrome is very well known. Actually, 40 to 45% of children with Down syndrome have congenital heart diseases, and out of these, 40% have AV canal defects of the complete type. There is also a partial type and various other subtypes, which we will see subsequently. Another common association of AV canal defects is with the heterotaxy syndromes, where you get asplenia, single ventricle, and so on. And their AV canal defects are again quite frequent. This is a condition which can be picked up on fetal echocardiography and therefore can be identified in the antenatal period. Though it has been recognized for a long time, it has gone through various terminologies. For example, Roger Edwards in 1948 recognized the morphology of the primum ASD in this defect. Then Edwards and Wakai coined the term. They added terms like partial, complete AV canal, etc. in 1956. So they are the ones who divided AV canal defects into complete or the partial type, which are the two broad types of AV canal defects. Then Bharati and Lev in 1980 added terms like transitional and intermediate. Now, partial to complete AV canal, there are a spectrum of changes that you will see. And for this, Bharti and Lev use the term transitional and intermediate types. Then in 1961, Rasteli described the common anterior leaflet, which is a very important landmark in AV canal defects. And in fact, based on the anterior common leaflet attachments, Rasteli also gave a classification for the complete type of AV canal defects, classifying it into A, B, C, etc. And we shall see about that subsequently. Now, Lillihei was in 1954 did the first repair. However, it was Kirklin, Watkin, Cross, etc. who used an oxygenator. They went in for open heart surgery and performed a repair of this defect. So, it is primarily a defect of the endocardial cushion development. Now, When you see the development of atrioventricular canal, it involves septation of the common atrioventricular orifice as well as closure of the atrial septum and the ventricular septum. Now here you have a common atrioventricular canal. This is the primitive stage in the development of the heart. Now soon enough, we have endocardial cushions. These are nothing but mesenchymal tissue which appear in the superior and inferior part of the common AV canal. So here you have an inferior endocardial cushion. This is superior endocardial cushions, and on each side you have the lateral cushions. In due course of time, the inferior and the superior endocardial cushions meet together and they divide the common atrioventricular canal into a right atrioventricular canal and a left atrioventricular canal with the lateral cushions on either side. Now this is a more diagrammatic representation. Here you have the embryological, very primitive heart with the primitive right atrium, primitive left atrium, and a common atrioventricular canal. Now this portion will constitute the primitive left ventricle. This portion will constitute the primitive right ventricle, which leads to the outflow, that is the conal trunk. Then between the so-called left and right ventricle, you have a primary interventricular foramen. At the same time, the muscular interventricular septum starts developing from the apex of from the center part of the apex of the heart. So it develops from here, goes upwards, and with the further curvature of the heart, you see the development of the endocardial cushions, superior and inferior endocardial cushions, the lateral cushions, and the muscular interventricular septum going up to meet these endocardial cushions. And here you have the primary interventricular foramen. Now, with the complete division of the atrioventricular canal into right and left, there is further development of the muscular septum, and you have formation of the primitive left ventricle, the right ventricle, which are divided mainly by the muscular interventricular septum, which goes up to meet these endocardial cushions. In the meantime, there is also orientation of the left ventricle towards the conotruncal outflow tract. So, you have the superior bridging leaflet, you have the inferior bridging leaflet, you have the left lateral cushions, the right lateral cushions gets divided into anterosuperior and right mural leaflet. Now the anterior mitral leaflet, it forms from part of the superior bridging leaflet and part of the inferior bridging leaflet. Now if they fuse together totally and nicely, you have the anterior mitral leaflet and you have the posterior mitral leaflet formed from the left lateral or left mural leaflet. The septal leaflet is formed from the inferior endocardial cushions. Now, if for some reason this superior and inferior endocardial cushions don't meet completely, there forms a cleft in the anterior mitral leaflet. So septal leaflet you get from the remaining portion of the inferior endocardial cushions. The anterior tricuspid leaflet develops from the superior endocardial cushion and the right lateral leaflet. The posterior leaflet is the inferior portion of the right lateral cushion. So this is how usually the mitral and the tricuspid valves are formed. Now, the atrioventricular cushions are a little large relative to the size of the atrioventricular orifice. The atrial septum meets the endocardial cushion bang in the middle, but the ventricular septum, the muscular septum, comes more a little to the right of the endocardial cushions. And therefore, you find a kind of endocardial cushion tissue which separates the right atrium from the left ventricle. And somewhere here at this junction, you will also have the membranous septum. So if you have any defect here, you will have a communication between the right atrium and the left ventricle. So again, this is the normal heart, the aortic valve wedged between the mitral and the tricuspid leaflet. So here you have anterior mitral leaflet, the posterior mitral leaflet, septal leaflet, the posterior leaflet, and the anterior tricuspid leaflet. So you get a cleft when the superior bridging leaflet and inferior bridging leaflet don't meet completely. They meet incompletely and form a cleft in the anterior mitral leaflet. This is the posterior mitral leaflet, anterior tricuspid leaflet, and the posterior tricuspid leaflet. So this is what you will get in a partial AV canal defect. When you have a common AV canal defect, you have a completely superior bridging leaflet and inferior bridging leaflet. There is no fusion between the superior and inferior bridging leaflets. The crest of the ventricular septum is bare. And then you will have the left mural leaflet, which is equivalent to the posterior mitral leaflet. And then you have two other tricuspid valve leaflets, the right anterosuperior, which would have formed the anterior tricuspid leaflet, and part of the right inferior, which would have formed the posterior tricuspid leaflet. But the hallmark is that the superior and inferior bridging leaflets do not fuse together at all. The crest of the ventricular septum is bare. But there are some spectrums of cases where you may find some kind of caudal tissue being seen across the crest of the ventricular septum. So what are the main features of AV canal defects? So it is primarily a defect of the atrioventricular septum, and therefore you get abnormalities of the atrioventricular valves. As I told you, there are two main types, the partial and the complete. In the partial, what you have is an ostium primum defect. You have two annuli, two atrioventricular annuli, and two atrioventricular valves. In the complete type, you have a primum defect, you have an inlet VSD, and a common atrioventricular orifice with a single AV valve. So these are the basic differences between partial and complete. So partial defects is because of incomplete fusion of the superior and inferior cushions, which form a cleft in the anterior mitral leaflet. Whereas in the complete AV canal defect, there is total failure of fusion of the superior and inferior leaflets, and you have separate anterior and posterior bridging leaflets, which are seen along the crest of the ventricular septum. So this is a more diagrammatic representation. This is the right atrium, left ventricle, and the right ventricle. So here you have the mitral leaflet and the septal tricuspid leaflet, the atrial septum, including the primum septum, have fused with the crest of the ventricular septum. So this is normal. In a partial AV canal, you find, please note here that the mitral valve is attached at a higher level than the tricuspid valve. When you come to partial and complete AV canal, both the mitral and the mitral comes down, and it is at the same level as the tricuspid valve. In partial, there is an ostium primum defect, but no other defect in the ventricular septum. In the complete type, you have an ostium primum defect, an interventricular septal defect, and a common AV valve. This part is the mitral, this part is the so-called tricuspid valve, but they are at the same level, and this is important. Now, when you look at the partial AV canal, there are some subtypes. So here you have the classical partial AV canal defect. Only an ostium primum defect, 2 atrioventricular orifices, no defect in the ventricular septum, membranous or muscular or whatever. Then we come to the next stage, which is the transitional type of AV canal, partial type of AV canal defect. Here you have 2 atrioventricular orifices, an ostium primum defect, and a very small interventricular communication. Usually this is covered by a lot of the caudal leaflets. In the complete AV canal type, you have a common atrioventricular orifice, and you have a primum defect, a huge interventricular communication. In the intermediate type, you have again ostium primum and an interventricular communication. There is a single atrioventricular ring, but you can see 2 distinct atrioventricular valves. So this is the intermediate type of AV canal defect. So actually it's a spectrum between partial and complete AV canal defects, and in which we have further subdivided into the transitional type, which is more towards the partial type because it has got 2 atrioventricular orifices, and the intermediate and complete type, which have a single atrioventricular orifice. This is the same thing in a diagrammatic manner. And these are the further subtypes of complete AV canal defects, type A, type B, type C, which we will see. This is Rastelli's classification. So this is the same thing what you have seen earlier. Normal heart, this is the mitral valve. This is the cross-section of the heart at the base. The aortic valve wedged between the mitral and tricuspid valve. In the complete AV canal kind of defect, you have a bridging leaflet here, that is the superior bridging leaflet, an inferior bridging leaflet, and here is the crest of the ventricular septum, which is bare, and the 2 parts of the orifices. In the partial AV canal, you have a cleft here in the mitral valve. We will see better picture. The crest of the ventricular septum is not at all bare, and you have 2 distinct atrioventricular valves. So this is a much better picture. This is the complete type of AV canal. Part of it is the left ventricle, part of it is the right ventricle. Here you have the bridging leaflets, the superior and the anterior bridging leaflets. See, the crest of the ventricular septum is smooth and bare. In contrast, this is the Partial AV canal defect, this has been operated. So you see a ragged ostium primum defect. This is the mitral valve which is cleft. There has been an attempt to suture this cleft. You see bits of the suture. But at no point do you see the crest of the ventricular septum. And there are two distinct orifices. So because of the, now coming to the more complete AV canal defect, and to some extent, some of these features are also common to the partial AV canal defect. Because of the common AV junction, there are some changes which happen which are important. And that is the unwedging of the aorta. In a normal heart, the aorta is wedged between the mitral and the tricuspid valve. And there is downward displacement of the anterior mitral leaflet, and it comes to the same level as the septal tricuspid leaflet. So they are at the same plane. Otherwise, mitral insertion in a normal heart is higher than the tricuspid. Then you have marked elongation of the left ventricular outflow tract. And this occurs because of a disproportion between the length of the inlet septum and the outlet septum. The ventricular septum is actually scooped out, but you have a trifoliate left aortic valve. You can get other associated defects in the atrial and ventricular septum too. Now, this is a very classical description, the gooseneck appearance of the left ventricular outflow tract. This is because the aortic outflow is, the aorta is pushed upwards. It is not wedged between the mitral and tricuspid valve. So the left ventricular outflow is elongated, and it is called the gooseneck deformity. So in an echo, you see this is the gooseneck deformity. This is the body of the goose, the neck of the goose, and the head of the goose, like this. And this is on angio, the body of the goose, the long, narrow neck of the goose, and the head of the goose. So gooseneck appearance in AV canal defects. In a normal heart, you see the length of the outlet from the aortic valve to the apex and from the apex to the mitral valve. These two lengths are almost the same. But because of the aortic valve which is pushed upwards, this outlet septum becomes much longer than the inlet septum. And this is what gives you the gooseneck appearance. So coming to partial AV canal defect, that is ostium primum defect. This occurs inferior and caudal to the limbus of the fossa ovalis and is associated with a cleft in the mitral valve. So you get two annuli, the mitral and the tricuspid annuli, which are distinctly seen. You get a ostium primum defect and a cleft in the anterior mitral leaflet. These primum defects are large and they are antero-inferior to the fossa ovalis. Posteriorly and superiorly, you will find a crescentic rim of the fossa ovalis, and anterior and inferiorly, you will have the mitral and the tricuspid valve. Here again, you will find the mitral and the tricuspid valves at the same level. And this is because the mitral annulus is displaced towards the apex. So here also you will get a gooseneck appearance. So this is seen from the right atrium. You have a primum defect here, and you have the tricuspid leaflet here. This is the right ventricle. This is the right atrium. Now the same heart as seen from the left side. This is the crest of the ventricular septum, which is not bare. And here is the anterior mitral leaflet from here to here. But it is big, but there is a deep cleft here. So this is the cleft in the anterior mitral leaflet. And it is an integral part of partial AV canal defects. Here you can see a closer look at the crest. This is part of the anterior mitral leaflet, and here you see the cleft. This is the top of the ventricular septum, the ostium primum defect. Here again you see the deep cleft in the anterior mitral leaflet. This is the left ventricular outflow portion, ostium primum defect as seen from the left atrium. So in partial AV canal, the communication is interatrial rather than interventricular. In all AV canal defects, you have a scooped out appearance of the inlet ventricular septum. And as I showed you earlier, the distance of the mitral annulus to the LV apex is less than that from the aortic annulus to the LV apex, so giving you the gooseneck appearance. Now, the cleft in the anterior mitral leaflet is directed towards the mid portion of the ventricular septum. Please remember that you can get isolated clefts of the mitral valve, not related to AV canal defect. These clefts are directed towards the aortic annulus. The mitral orifice is triangular in shape. The normal orifice is elliptical. So here is the primum defect, the tricuspid valve, as seen from the left side. Here is the cleft in the mitral valve. This is the scooped out appearance of the ventricular septum, the long LVOT outflow tract giving you the gooseneck appearance. There can be some obstruction in the subaortic region, as you can see here. Other mitral valve anomalies that you can see with partial AV canal are a parachute mitral valve when there is a single papillary muscle, a double orifice mitral valve, LVOT obstruction in the form of discrete subaortic fibromuscular ridges, septal hypertrophy, left AV valve abnormal caudal attachment and abnormal papillary muscle. You can have sometimes a secondum defect, in which case it will be almost like a huge defect in the atrial septum, giving the appearance of a common atrium. Persistent left LVC, pulmonary stenosis, tricuspid stenosis or sometimes atresia, for triatriatum, coaptation of the aorta, PDA, perimembranous VSDs, total anomalous pulmonary venous connections, and hypoplastic left heart, TOF, etc. You can get a malaligned atrial septum, and both the right and the left AV valves are visualized from the right atrium in spite of the malaligned atrial septum. When there is near absence of the atrial septum, that means you have a secondum and a primum defect, you have a common atrium. This is so commonly seen in heterotaxy syndromes. Now, what is the way to repair partial AV canal defects? One is, of course, you have to close the primum interatrial defect. And then you need to repair the left AV valve. So this repair can be done by either bringing the edges of the cleft together with sutures and restore the valve competence. However, if the cleft is very deep, then you treat the left AV valve as a tri-leaflet valve. The cleft is like a commissure, and then you only do an annuloplasty. So it all depends on the morphology of the cleft. So this is almost like a common atrium, and this is the left side. This is the right side. You have the tricuspid valve and the whole of the septum whole covered by valvular tissue. The same thing as seen from the left side, a very deep cleft, a large interatrial communication. Same thing, you have a large defect here and a cleft, a closer view of the cleft of the mitral valve. Now complete AV canal defects. Here you have interatrial and interventricular septal defect and a common atrioventricular valve spanning the entire atrioventricular orifice. Membranous septum is deficient. So here you have the bridging leaflets, the bare ventricular crest, and a common atrioventricular orifice. There is no separate mitral tricuspid valve in the classical sense. So complete AV canal, you have 5 leaflets. One is the posterior bridging leaflet, which is actually a fusion of the septal tricuspid leaflet and the inferior half of the mitral leaflet. 2 lateral leaflets and a right-sided anterior tricuspid leaflet here and an anterior bridging leaflet. That is the superior half of the mitral leaflet and the tricuspid leaflet. The extent of the bridging of the anterior leaflet into the right ventricle is the basis for the classification of AV canal defects into A, B, and C. The most common is type A. The anterior leaflet is divided and the medial chordae are inserted into the crest of the ventricular septum. And this is frequently seen in Down syndrome as an isolated defect. Now here we have the bridging leaflet. This is the anterior and this is the posterior bridging leaflet. This is the right ventricle, and here you have the bridging leaflet attached by chordae to the crest of the ventricular septum. So there is not much of the bridging leaflet, anterior bridging leaflet that is seen in the right ventricle. In type B, the common leaflet is divided and you have medial chordae inserted into the papillary muscle or into the right ventricle, very close to the ventricular septum. And type C, it is often associated with other defects like DORB, heterotaxy, where the anterior bridging leaflet is a single large valvular structure without insertion of chordae into the ventricular septum and a large ventricular septal defect. Now this is type B. Here you have the anterior bridging leaflet and you see the papillary muscle attached very close to the on the ventricular septum on the right side. And on the left side, you have another papillary muscle tethering the anterior bridging leaflet. Then type C, you have, this is the posterior bridging leaflet, anterior bridging leaflet. It is described as a free floating anterior bridging leaflet. And there, the crest of the ventricular septum is where there will be no caudal attachments of the anterior bridging leaflet to the crest of the ventricular septum. Then you have a small anterior septal leaflet and the posterior leaflets, mural leaflet. From the left side, see how smooth the crest of the ventricular septum is. And you can put a probe and see that there are no caudal attachments at all, nothing to attach the anterior bridging leaflet. Here again, the crest is totally bare, so it just seems a little nodular. So you have 5 commissures, 5 papillary muscles. 2 of the papillary muscles are on the left side, just like you have the anterior papillary muscle and the posterior papillary muscle, but they are oriented closer than normal. The posterior papillary muscle is away from the septum. The anterior papillary muscle is closer to the interventricular septum. Many times the AV canal defects show an unbalanced defect. That means one of the ventricles is smaller than the other depending upon the orientation of the atrioventricular valve. So one ventricle and its atrioventricular valve component is hypoplastic. Other ventricle receives a larger portion of the AV valve. Most commonly, you have a dominant RV and a smaller LV. In addition, you have the right atrium and pulmonary artery are dilated. The RVOT bulges anteriorly and the right ventricle is hypertrophic. The left atrium is dilated. LVOT is long and narrow, as we have seen, and most important are parasternal and subcostal views. So here again, you have the common AV valve. See the hypertrophied intermuscular septum, hypertrophied right ventricle. Again, the common AV valve, but there is some attachment of the anterior mitral leaflet here. This is the right ventricle, anterior mitral leaflet here. You see some knobby bits of valvular tissue. The left ventricular outflow showing the typical narrowed outflow giving the gooseneck appearance, the scooped out ventricular septum. This is the LV portion. That's the aortic valve. You can have various degrees of subaortic obstruction. You can have a parachute mitral valve in AV canal defects, double orifice mitral valve, hypoplasia of right ventricle or left ventricle, depending upon the whether the is unbalanced type of AV canal defect. Allostetrology, subaortic stenosis. As far as the conduction system is concerned, the AV node is displaced posteriorly, very near the orifice of the coronary sinus. And the His bundle is displaced along the inferior rim of the septal defect. So there is a prolonged intraatrial conduction time and leading to a prolonged atrioventricular node conduction time. So you may get first degree AV blocks. Now, when do you do the repair of AV canal defects? The most common problem with AV canal defect is pulmonary vascular obstructive disease. And therefore, early repair is necessary before pulmonary vascular obstructive disease develops. What is generally advocated is elective repair before 6 months of age. If the infants are symptomatic, pulmonary artery banding is often recommended. And the repair involves closure of the interatrial and interventricular communication and construction of 2 separate competent atrioventricular valves. So, surgical repair of common AV canal is usually accomplished at the age of 2 to 4 months. It is advisable. And there are various methods which have been advocated. One is using a single patch technique. This is the traditional method. What is used nowadays is a standard double patch technique. or a modified single patch technique, which is known as the Australian technique or the Nun technique. Then various other additional procedures have been reported sporadically. Everybody tries to use their own ideas. These include 1.5 patch, a central patch, or no patch technique. So this is how you would put two patches, one in the region of the ostium primum, another one in the region of the interventricular communication, and you try to form two atrioventricular orifices. So this is the two-patch repair, which is most frequently done. So with this, I come to the end of my talk on AV canal defects, and I hope this has been a simple presentation and you have got a good understanding of AV canal defects. Thank you. So if there are any questions, you are welcome to ask them. If not, then I will take your leave and thank you for your kind attention.